Well, welcome everybody, and thank you all for joining us tonight. This is the program called Minnesota End of Life Options, and we are the League of Women Voters of Minnesota of the White Bear Lake area. And my name is Liz Lauder. I'm one of the co-presidents of the League of Women Voters White Bear Lake area, along with Becky Stiegmeyer. And I want to welcome you to this presentation. A little bit about the League of Women Voters. We've been working for the past 100 years to educate voters about the candidates for public office, as well as important public policy issues of the day. We also advocate for changes in public policy after arriving at our positions through a process of study and the consensus of our members. The three levels of membership in LWV are similar to the structure of our democracy. So there's a local, a state, and a national league. And when you become a member of a local league, that means you're also a member of the state and the national league as well. The White Bear Lake Area League serves 32 communities in the northern eastern part of the Twin Cities metro area. We cover 3 counties and 3 school districts. We meet once a month, and sometimes that's in person, but currently we are doing Zoom meetings because of the COVID-19 pandemic. You can choose to attend a daytime or an evening meeting. To find out more about the League of Women Voters White Bear Lake area, and to become a member or to donate to our group, you can visit our website at www.lwv-wbla.org. And I put that in the chat if you wanted to see that. Membership is open to women and men who are 16 years of age or older, and you don't have to be a US citizen to be a member. Okay, that's a little bit about the league, and I'm going to tell you a little bit about the format for the meeting tonight. I'm going to introduce the member of our league who has been the lead organizer for this program, and she's going to introduce the speaker and tell you a little bit about the program. It will be recorded and available to view later on our YouTube channel, and you can find the link to that recording on our website. And that's also where you can see a copy of our speaker's slide presentation and the other accompanying documents that she's going to be talking about. And I think a copy of these documents will also be sent to you via email if you're a member and are on our distribution list. The program will last approximately 1 hour to 1 hour and 15 minutes, and we will not have a break at all. Your microphone has been muted, or please mute your microphone while our speaker is talking so that there are a minimum of distractions. And you may unmute yourself at the time that we have for questions. Our speaker is going to talk for about 30 minutes or so, and then she'll break and give us the time for questions. And you can ask your questions either verbally, or you can put your question in the chat. So if you take a moment right now to find out on your own device how you can get into the chat and pose a question there. Otherwise, if you wanted to do it verbally, you could you can unmute your microphone, and then you can press and hold down the space bar if you wanted to do that. If you're having trouble finding the unmute button, you can hold down the space bar, make a small, like clearing your throat, just so that we can see the little, your video, your picture comes up on the screen so that I can see who wants to ask a question, and you can just raise your hand and I'll see you and call on you. So then after the presentation, we'll have a few closing announcements, and then we'll have a couple of people are going to be giving you some information about some other things happening with the league, and then I will end the meeting. So that's all that, and I'm going to turn the presentation now over to our member, Shannon Moore. Shannon is our secretary. She's been with the league for a couple of years now, and we put her to work right away because she's just delightful. And she took an interest in this topic, and so she has been communicating with our speaker, and so she knows more about her than I do. So I'm going to turn over the speaking to Shannon.
Welcome to our January unit meeting on the Minnesota End of Life Options Act presented by Dr. Rebecca Thoman. Dr. Thoman is currently on the Minneapolis League Board, as well as serving as Development Director. I first became aware of the Minnesota End of Life Options Act when I served as a league delegate at the Minnesota League Convention in June. Dr. Thoman, offered several presentations on the subject. The goal was to have a vote of concurrence at the convention, but before the vote, there was a discussion period with many delegates weighing in on the subject. The issue that was mentioned multiple times was that people did not know what was involved in this important legislation. A vote was taken and there was not enough votes for concurrence. I contacted Dr. Thoman and asked if she would speak at our unit meeting about the Minnesota End-of-Life Options Act and the league work to get it done. Besides being a league member, Dr. Thoman leads the Doctors for Dignity Initiative for Compassion and Choices, a national nonprofit working to improve care and expand options at the end of life. Rebecca has worked in public health policy for more than 2 decades, advocating for tobacco control, access to health care, and gun violence prevention. She ran for the Minnesota House of Representatives in 1999. Rebecca, welcome and thank you for being our guest tonight.
Thank you so much, Shannon. That was a very nice introduction. I am going to share my screen and we practiced this, so we're very confident it's going to happen. Yay! Well, thank you. Shannon did a very nice job of summarizing some of the process that's been involved in the league taking on this conversation, and I'll be enhancing some of what Shannon has already said. But yes, the League of Women Voters of Minneapolis took up this issue back in 2019 and we used the Utah League that had already done a pretty comprehensive study. We've added some additional updates because that study was done in 2016. So our committee got together and pulled together the more recent data for the past 4 years and created a little addendum. And then we did a civic buzz on this, which is our monthly public meeting. We had a recording on our cable channel, and then we had study groups. Each unit studied this, and we did we came together and voted as a group and decided that we did want to concur with the Utah position and then bring this to the state. And that's how we got to this point in time. So I'm going to be talking about, I want to start with a definition because I know that there's a lot of misunderstanding about what exactly this whole process is. And so this is really our opportunity to get clear on exactly what we're talking about here. And so what we're talking about is the practice of medical aid in dying, and that is the legal terminology that's used. It's a practice in which a terminally ill adult who has a sound mind, so they are able to make healthcare decisions, they can ask for and receive a prescription medication from their doctor, which they can then self-administer for a peaceful death. And I'm going to talk to you more about what this exactly entails. And often people will say, oh, you mean death with dignity. So this bill actually has been introduced since 2015 in the Minnesota legislature. Senator Chris Eaton and Representative Mike Freiberg have been the chief authors every year since then. And as I said, the League of Women Voters of Utah did a fairly comprehensive survey or study, and other state leagues have concurred with the Utah League, including Maryland, New York, Connecticut, Delaware, and several other leagues. And I do want to go back to the terminology because people think death with dignity, and the Death with Dignity Act is the name of the Oregon law, which Oregon was the first state to have such a law. It passed was enacted in 1997. And that's become synonymous with the practice, but we don't use that terminology much. It is the proper name of the Oregon law, but we've had pushback from people who say, you know, when you call this death with dignity, you're saying this is the only dignified way. You're taking claim to dignity, and we don't intend to do that. So back since about 2014-15, most states have been calling this End-of-Life Options Act or Our Care, Our Choice Act. So the name of the bills have changed, but the practice is the same, and the practice is known as medical aid in dying. And so this map just shows you there are now 10, the light blue or teal colored states are states where medical aid in dying legislation has been enacted and is currently authorized. The dark blue states have introduced legislation, and the yellow states are where there are active grassroots organized volunteers working on the legislation. And so just to put these in perspective for you, since, like I said, Oregon was the first state to pass this in 1997. And it wasn't for another 10 years until Washington state then passed a similar law by ballot initiative. And that same year, Montana had a court ruling that declared that there was nothing illegal about the practice in the state of Montana, therefore it was not prohibited. Vermont was the first state to pass the legislation to pass this by legislation as opposed to ballot. That was in 2013. And then momentum has begun to build since 2015 when California passed the law. And some of you may remember there was a very public story about a woman named Brittany Menard, was in People magazine. She had a brain tumor and moved from California to Oregon to take advantage of the law. And when her family returned back to California, they were huge leaders in this effort, and the law passed in California in 2015. So this is where our addendum has added to the information, because since then, Colorado passed the legislation in 2016, followed by Washington, D.C. in 2017, Hawaii in 2018, in 2019, 2 states, Maine and New Jersey. And then just last year, New Mexico became the 11th jurisdiction, 10th state. So about 22% of the population of our country currently lives in a state where this medical aid in dying is authorized. I wanted to take just a minute and put this in perspective as to where this fits into end-of-life options. And as we think of end-of-life options, of course, the first thing is pursuing all life-sustaining treatment. And I would say that that is basically the default in medicine, is that everything is done unless otherwise. And of course, you can refuse life-sustaining treatment, and you can also discontinue treatment after you begin it. Some people will many people will opt for hospice care, which is available in the last 6 months of life. And that is strictly comfort care when you are no longer treating the disease in an effort to cure it. Voluntary stopping eating and drinking is less known, but it is legal in every state. And it is when people at the end of life, usually they have a terminal disease or a late stage chronic illness, decide that they are done, and they will literally stop eating and drinking. And done with medical supervision and support, people can successfully stop eating and drinking to hasten death, and it takes about 7 to 10 days, in which time their body will dehydrate. So it is not easy, but for some people, it's a viable option, particularly people who may have a late stage cancer where they really don't want to eat anyway, and they may be losing a lot of their muscle strength. So that is an option. And then, of course, sedation to unconsciousness, which is maybe done typically for a patient who can't speak for themselves anymore. They're clearly suffering. They will be given enough medication to go into a comatose state where they will be maintained at that state, and food and liquid will be stopped and they will dehydrate. Or if the pain or discomfort is very severe, they can be given high enough doses that might actually suppress their breathing. And so some people will have a hastened death through sedation to unconsciousness. And then so medical aid in dying is kind of the other, so this fits on this continuum where it is an option only for people who, like I said, are able to make their own decisions and ask for this proactively. So it would not apply, for example, to somebody with dementia. So I'm going to talk about who qualifies. Most of the laws are very similar. The basics of the laws in every state are similar. And I'm going to focus on what the proposed legislation in Minnesota is like. And who qualifies under this legislation. You'd have to be an adult age 18, so this does not apply to children. You have to be a resident of the state. You have to be terminally ill with a 6-month or less prognosis. And that it was selected because that is the qualification for hospice care. And hospice really is the gold standard at the end of life. So people who are dying and terminally ill and at the end of life, our preference would be people are enrolled in hospice care and getting all of that support and comfort care. And then, of course, mentally sound. And that means they have to be able to make their own healthcare decisions. They have to have memory intact. They have to understand what the consequences of their choices. They have to be able to give fully informed consent. And then finally, they also have to be able to self-administer the medication. So that usually means swallowing, although there are ways people could use a GI tube, a gastric tube, or a rectal catheter, but infusion, IV injection is not permitted under this law. So this is not euthanasia. If you think about, how we take care of our pets, we euthanize our pets at the end of their lives, we inject them with a medication. This is not euthanasia. The individual must be the one to decide to do this and go through the steps and actually ingest the medication. There's also a prescribed process in the law where a patient has to first submit a written request. They have to make a verbal request to the, and we call the providers the attending or prescribing provider, and then the consulting provider. And they would then do be evaluated by that physician. And in Minnesota, we have added nurse practitioners as eligible providers. The only other state that allows nurse practitioners is New Mexico, but there have been bills in Oregon, Washington, and California to try to expand that qualification, because as long as nurse practitioners have independent prescribing authority, then we include them in a qualified provider. And so the attending physician or nurse practitioner determines that the patient is eligible, that they have a diagnosis, that they have decision-making capacity, discusses all alternatives. We added in our bill that we would like the provider to be sure to refer the patient to hospice if they're not already enrolled. And as I talk more about what we know about how the law works, you'll find that actually most people, the vast majority of people, are already enrolled in hospice when they make their first request. And then they have to refer to a second physician or nurse practitioner who goes through the same steps again to confirm eligibility or prognosis. If there is any question from either provider about the person's mental capacity, then they should request, and they must request, a mental health assessment. And that mental health provider will be the final word. Some other safeguards that are built into the law that are similar in all the other states is that absolutely no health professional or institution is required to participate. So as with anything else, providers can opt out, including pharmacists, nurses, etc. There's also liability protection built into the law so that a health professional that follows the steps as outlined in the law are protected against any criminal or civil liability. And then finally, there is, I forget the term for this clause, but it clearly defines that medical aid in dying is not suicide, assisted suicide, mercy killing, homicide, etc. And this becomes important for things like insurance policies. I always get the question, will this affect my life insurance? No, and that's because this provision is in the law. So I also wanted to just point out the supplemental material that we added to the original report. What we did was updated the year-end data reports. So just about every state where this is authorized does an annual report at the end of the year. And they give data on cumulative data, not identifiable, on the patients who use it. At every step along the way, physicians have to submit a form, pharmacists have to submit a form, and those forms are used to track some of this information. Oregon has the most extensive data collection, and so we typically use that set to talk about it. But what we've seen is that as the data has accumulated in Washington, California, other states, the patterns of use are very similar, and I'll talk about Oregon, but know that that also applies to the other states. Then we also did some updates because some major medical associations have changed their stance on this in the last 5 years. And then survey information specifically from Minnesota was available from 2016 that the original report didn't have. So I'll cover some of this for you. And if anybody wants to read the details about how medical aid in dying has worked, I really do encourage you to go to the original reports. Every year, the Oregon Public Health Division has a next year summary. I'm including the report from 2020 because that's the one that was in our addendum. However, there have been one or even two now, maybe additional reports for the next couple of years. But the data shows, so from 1997, from between 1997 and 2020, so 23 years, a little under 3,000 patients received a prescription under the law, and just under 2,000 ingested the medication. So 2 out of 3 patients who received the prescription actually went through with ingesting it, and that is all we know. We do not know why patients who didn't use it. So that information isn't collected. So we can guess that either they just decided they didn't need it, perhaps they lost the ability to use it for whatever reason because of their disease progression. We just don't know. So that was cumulative data. This data is just from the year 2020. And of course, the major group of patients who utilize medical aid in dying are cancer patients. And that's true in every state. It's by and far the #1 diagnosis, followed usually by ALS or other neurodegenerative disorders. That's a large group. And then other cardiovascular, lung disease, that would be about 10%. And that's pretty true across the board. 95% of the patients from Oregon that year were enrolled in hospice at the time, and 92% who utilized this died at home. So the number is not as high in other states. It doesn't reach 95%, but it's usually between 65 and 80% enrolled in hospice. And that just shows you that, people are treating their disease, getting the maximum care they can, and in some instances still wanting this as an option. The last piece of data I put in there, I think is important for one reason. 96% of the people who use this are white, and the majority are more highly educated. And the reason for mentioning that is that because when the laws first passed years ago, there were some fears, and that was discussed in the report too, concerns of abuse, that this would somehow be used against minority or poor or elderly. And fast forward 20 some years, it's really played out to be the opposite, where it has kind of become a middle class privilege because access is more difficult for people because there are so many steps to go through and there's no health coverage from government programs. You have to be able to afford it, and you have to be able to get through the steps with your family's help. More data, just to give you an idea, in the year 2019, 142 physicians in Oregon wrote 370 prescriptions. So it's a small group of doctors, and these are physicians who are treating patients at the end of life. And there's not just a single doctor death out there writing all the prescriptions. It's really been integrated across providers and is part of one end-of-life option, not a special standalone kind of thing. And there's also in Oregon, there's absolutely been no history of any abuse. No physician has been disciplined. There's been no legal action. So concerns of abuse have not materialized. And actually the laws do say that efforts to coerce or try to persuade somebody either to use or not use the law are illegal and punishable. But there has been absolutely no problem with the law. They have worked as designed, and that's, I think, because there are ample safeguards. And then again, I urge you to, if you're interested, to look at the Oregon reports. They have some more information about the medications that are used, the time to death. I would say as medication protocols have changed, the time to death has become more standard, where people typically will, after ingesting the medication, they'll fall asleep within 10 minutes to an hour, and then will stop breathing within a couple hours, although it can be longer. And I think the longest was 24 hours. So that kind of data is available too, if you're interested. Some of the medical groups that have changed their positions in the last 5 years include the American Academy of Family Physicians, which has, and typically what these groups do is, there's been a long historic opposition to, and they called it assisted suicide. And I think they've moved more toward where they similarly stand on something like abortion, where they're not for it and they're not against it, but they want safety parameters around it. And then within that, people make individual ethical decisions based on their situations and their priorities. The American Academy of Hospice and Palliative Medicine also similarly adopted a neutral stance. The American Academy of Neurology did similarly, and that organization has a high level of patients. I think if you looked at a category of patients, ALS patients are the highest rate of users of this. Even though their numbers are not high, their rate of use is high. And then a couple of years ago, the American Nurses Association also reviewed this, and their ethics committee came out with a neutral stance, saying nurses need to understand this, know about it, and make decisions about whether they're no longer forbidden to participate. And then the American Medical Association didn't change its position, but it did go back and reinterpret its code of medical ethics with a preamble that indicates that the doctors who provide medical aid in dying are doing so on the right of conscience, and they're not violating any ethical standards for the practice of medicine. So that was also new. That was a couple of years ago. And then 12 state medical societies have similarly said we're no longer against this, and that does include the Minnesota Medical Association, which changed its position, I think, in 2016 or so. Then we included some data from surveys that were done in Minnesota. A survey was done. This was a statewide polling firm that did it, and they asked about medical aid in dying and defined it with the language of, a terminally ill person, 6 months decision-making capacity. Do you support this as an option? And overall, the majority, 73%, was yes. When you broke it down by political party, there was majorities in every group, metro and urban majorities, and even by religious affiliation, there were majorities in every religious group. Catholics were at 71%, which is notable because the Catholic Church is a major voice of opposition. But if you actually ask Catholics, the majority are in support. And then people who live with a member of their family with a disability. And that's another group where you'll hear a lot of loud opposition. But when we actually survey people, we find majorities support this as an option. And then, of course, the Holy State Fair, that's what we all that's how lawmakers decide what Minnesotans really want. So there was a state fair survey question in 2016, and it's actually written on the screen how it was worded: when a mentally competent adult is dying from an incurable, irreversible medical condition expected to end their life within 6 months, should they be allowed to obtain a prescription self-administered to end their life? 68% said yes at the state fair. The Utah study also does a nice job and goes into a little bit more depth than I will on kind of the pros and cons. What's the pro and con debate? Of course, the pro is usually this is about autonomy, relieving suffering. It's been safe. There's been no evidence of abuse. The cons tend to be moral objections. This is wrong, or doctors thinking this goes against the Hippocratic Oath. Some hospice providers have argued this is unnecessary. They can relieve all suffering without hastening death. And then there are still, you'll still hear the voices saying, well, this is going to lead to euthanasia. This is going to be killing people with disabilities or minorities or elderly. And I think those arguments are the same as they were 25 years ago. However, most of the data has shown those to be not materialized. So then we talked, I think our league looked at this and said, does this align with league values? Yes, we educate the community on important issues of the day, but should we take a position? Does this align with league values? And we found that we thought it did in terms of individual autonomy is something, individual privacy, religious freedom, in that this would be a separation of church and state issue, and then equal access to healthcare where certain states have this and other states do not. And then just to emphasize that this is a state issue. So the League of Women Voters of the United States probably wouldn't take a position on this, or might not, because it's not a federal issue. This actually went to the Supreme Court back in the 90s. And some of you may remember Sandra Day O'Connor wrote the position saying that this is, it's not something in the Constitution that the federal government should have a say in, and it goes back to the states. So this is really a state by state issue, which is why it's appropriate for the state league to be the one to make a determination on whether or not our state has a position. And that was our, thinking for then taking the concurrence. So this is the actual Utah position. The league state law should grant the option for a terminally ill person to request such a legislation should include safeguards against abuse. So we concurred with that, the Minneapolis League did. And two other local leagues also concurred that year, Golden Valley and I think Plymouth Wayzata. And then so we've been, since the last meeting, we've been just trying to get out and have people become aware of this, get educated about it. And our goal is to bring it back again. We actually got 58% support for this at the convention, and we needed 60%. So it was very close to passing. But there was a lot of, gee, I never heard of this. And even though we tried to do some education, it was tough to get people's attention on that. It was COVID year and all that stuff. So after convention, this committee of which Shannon has been a participant is doing a job of getting this out now to local leagues to study using our materials. You're welcome to have all of our materials, talk about and determine whether or not you agree with concurrence. And like I said, we were going to bring this in 2020, but that meeting was canceled. And so 2021, the concurrence failed, but we had 58% of the vote. So we're intending to bring it back to council again this year, and hoping that more leagues will have the opportunity to learn about it and talk about it. And your delegates will have an opportunity to vote on this. Oh, so we had our committee and we're doing educational forums. So yeah, and we're intending to introduce a motion. So I thought I'd stop. That's kind of the end. I provided your group with the Utah study, our addendum materials, but I'm really open to any questions. If you'd like to talk about this, if there are certain things you'd want more information about, I will stop my sharing and we can go to questions. And I'm terrible about reading the chat, so I haven't even looked at it. So if there are questions in there, I'll take a look.
Right, thank you, Rebecca. Okay, I'm gonna take a look and see. I don't see any questions in the chat right now. So if anybody has a question and you want to ask Rebecca, you can unmute yourself. You can kind of cough discreetly, or you can wave your hand.
Looks like Barb has her hand up.
Yep, go ahead, Barb.
I'm interested in the mental health part of it. I understand that a person who is depressed is competent and capable. And would that qualify as a disclaimer, or how would a psychiatrist evaluate whether a person who is depressed is competent to participate?
That's a really good question, because when you look at major depression, one of the exclusions for major depression is when there is physical illness contributing to the symptoms that would be identified as major depression, like fatigue, difficulty, loss of appetite, sleeping, things like that. Those things can't be applied in the context of a chronic disease. But if you're looking at people who are in the last 6 months of life in a hospice setting, they are sad and they are grieving, but they don't necessarily meet a diagnosis of depression or treatable depression. Although hospices will often help people through their feelings of sadness and grief, but that is not, and people feel sad and grief and don't choose this. And people who are not feeling sad or grief choose this. So actually, if you look at some of the research around what's the profile of the person who typically requests medical aid in dying, it has much more to do with their sort of desire for control. They're wanting to end their lives kind of on their own terms rather than allow themselves to be put into a coma. They want to stay conscious. So it's not as much about I'm sad and I can't go on. So that is not necessarily connected to people who make this request. But everybody in hospice is evaluated regularly by a whole team of people who assess their mental status, and everything is done to help them feel the best that they possibly can. So but that's a good question. And I think the big question usually is, do they have the capacity to make this decision? And would depression be clouding their ability to make a decision? That's possible, and that could possibly rule it out. But it's not necessarily true that someone who's feeling sad is unable to make this kind of a decision, if you see the distinction.
Yes.
Yeah.
Yes.
Yeah. And the
but
mental health professionals are called in, if there's any question.
if a patient is not eligible for hospice, they can't participate in this. Is that correct?
It's not written that you have to be eligible for hospice, because eligibility in hospice those are Medicare standards, but you do have to have a 6-month prognosis. And that was selected because it's consistent with the hospice qualification. And we want people to be in hospice. And most people who use this are enrolled in hospice.
Thank you.
But it's not required specifically.
Great question. Thank you, Barb. Anyone else
Barb, do you have a
question?
background in healthcare? It sounds like you have some experience with this.
Well, I'm a music therapist, and my clinical experience was in psychiatry. And I just know that there are people who are chronically suicidal, and who make many attempts, and it's a terrible way to live. But this legislation would not be available unless the person had a physical diagnosis.
Right, a terminal illness. Yes, with a 6-month prognosis. Right.
Okay, thank you. Does anyone else have a question for Rebecca? Susan, do you have one? You have to unmute yourself, though.
I was wondering if any state that has passed a law has later rescinded it. Has there been any negative feedback in any state that has passed it?
No, but with the exception that Oregon was the first to pass it. And I think they passed it originally by ballot in 92 or 3. And then their legislature overturned it. And then they passed it again. The people did. So the one attempt to overturn it was then overturned by ballot again. So no, the only changes that have been made in the laws have been a couple things. One is that in these earlier laws, like Oregon has a built-in required 15-day waiting period. So between your first request and your second request, there's a mandatory 15-day waiting period. We didn't put that in the Minnesota law, in part because the process is its own sort of sets up, it causes you to have to take some time to do it. It takes so many steps that
we can't hear them.
I'm sorry?
Go ahead.
So one of the changes that was made in Oregon was that they allowed doctors to then, or providers, but they're only doctors in Oregon, doctors were able to waive the waiting period for patients who were so ill they couldn't live 15 days. And actually, California found that 20-some% of patients who requested this died within the 15-day waiting period. So it doesn't seem to add any protection, but it did seem to set up a barrier. So that is one change that's happened. The other change has been in allowing nurse practitioners to participate in addition to physicians. So those are really the only two changes that have happened in the laws.
I have one more question. What's been the experience? You said that it's been introduced since 2015 in Minnesota. What has been our experience in Minnesota in the legislature?
It was first introduced in 2015 and had hearings in the Senate Health Committee that year and in 2016. They were never voted on. Those were informational hearings. And then in 2017 and 18, there was nothing, there was no movement. And then in 2019, the House had a hearing on it in the House Health Committee. That was informational. So it's not ever picked up momentum where it's had more than one hearing in a session. So it's really at the beginning of the stages, because turnover in the legislature means you kind of have to start again with often a new crop of lawmakers. So each time there's been maybe one hearing with the exception of 2017 and 18.
I had a question about the self-administering part of the bill. What do other states do? Do they have such language in their laws?
Yes, they all require self-administration. They don't all explicitly say no injections or infusions, but later laws have added that just to clarify that for people. And really the challenge is often with ALS patients who will at some point lose their swallowing capacity. And they can, their family can mix up the medication and put it to their lips, but they have to be able to swallow it. So that's usually the more challenging, when people start to lose some of their functionality and may not be able to administer it and have to titrate and find the time, the best time to do that. But most people ingest it by orally.
Barb, you got a question?
I was also listening in at the convention when this was discussed, and it was very curious to me that leagues in the northern part and maybe more rural areas were not in favor of this at all. And I wonder what you think, despite the fact that you said the Catholic Church is extremely opposed to this, although individual Catholics might be in favor of it. What needs to be done to work within leagues that might have a lot of Catholics in them?
For me, it's always about education, because what I have found is that when people learn about this, they tend to be supportive, or at least they say, it's not for me, but if you want to do it, fine, as long as I don't have to do it. So I often find that just education, talking about it, understanding it more, people are more comfortable with it. My sense also was some leaguers, and not just outstate leaguers, felt that this was controversial. Oh no, do we really want to get involved in a controversial issue? And I think the argument was, it's too controversial to get involved with. And because the lawmakers are very split on it, it's very polarizing, we shouldn't take it up. And then the argument was, well, we take things up based on the issue, not based on the political stance of it. And we have other positions on things that are polarizing, like guns and climate change and things. So having a position enables us as individual leaguers who want to work on this to do that if they want to. It allows the state league to decide if at some point they want to really get involved in lobbying it. So having a position doesn't require anybody to get involved in it at this point, but having a position does allow those who want to get involved. So that's kind of that was the argument that I heard on both sides.
Thank you.
So,
Go ahead, Susan.
is there any move to put it on the ballot as a constitutional amendment or?
As you said, it would have to be a constitutional amendment. There is no initiative and referendum in our state. So the lawmakers would have to put it on the ballot. The pros and cons of that are that if you put something on the ballot, as opposed to writing a law, then the whole regulatory process of that is unknown when people vote on it. So usually you're voting on a couple sentences and not the actual specifics. So, they could argue that if you vote for something, you don't really know what you're getting until it's administered. So for that reason, it's kind of more clear or safer, kind of clearer to do it as a piece of legislation. But it could be, but the lawmakers would have to put it on the ballot.
And who would have oversight over this law when it's passed? Is there going to be, would there be oversight by like the Minnesota Department of Health or any kind of regulatory?
The only oversight would be that the Department of Health would be the one that would manage the data collection. There would be reporting. The reporting requirements generally go to the Department of Health, and they tabulate those things and put out annual reports. But like any other practice of medicine, it's regulated by the Board of Medical Practice and based on complaints and that kind of thing. So it would be like any other end of life option.
Very good. Anyone else have a question for Rebecca? Shannon, go ahead.
In the chat, Jackie had I. Were you waking? No, you weren't waving your hand. Okay.
So I was going to say that I was planning on going to the convention last year and voting yes on this, but I ended up in the hospital, so I couldn't vote, but there would have been one more yes vote.
It would have been one vote closer to passing that.
Right.
No one has asked this question, but I'll just bring it up because it's something that we hear a lot, which is, and Barb kind of alluded to it, is the idea of suicide. And, I think if you look at this medically, it's very different from what we would traditionally think of as suicide, because, suicide is often in the context of a mental disorder, mental health disorder, or stressor. It's a person who could live, but they have a treatable disorder and reversible, but they're choosing, not to treat it, or for whatever situation, the option is death versus life. In this situation, these people are going to die. There's no choose life. It's a question of how are they going to die at the end. And then, suicide is often, it's very secretive. It's done with violent means. This is planned, the family's involved, it's a peaceful death. The goal of this is really to maintain a sense of self and to maintain safety and comfort. Whereas with suicide, it's more destructive and violent. And so they're really very different things when you look at how it plays out clinically. And then, of course, the fact that it's defined legally as two different things is important to remember too. So if you refer to it, because assisted suicide is still illegal. I think there was a case here a few years back where some nurse, it was a man, got on a chat room where people were suicidal and talking about, and he was giving them advice on how to do it and trying to get them to stream it. That's assisting a suicide, and that's a horrible thing. And that is not what this is. So, the opponents like to call it assisted suicide, I think, because there's a lot of connotation around that and a lot of emotion. But, we don't use that terminology. So just to clear, when you hear that, I think it's coming from either people who don't understand or are intentionally wanting to conflate the two.
Jane Bacon, I see your hand is up. You can either unmute yourself or press the space
Sorry,
bar.
I thought I had.
There you go.
I'm wondering in other states where this is the law, whether there have been situations where the the person meets all of these qualifications and, wants to do this, and then maybe has family members objecting, or because sometimes people seem to feel that they ought to intervene in other people's life decisions to protect them. And I'm just wondering if that has come up at all, or even in some cases, medical people sometimes intervening because they don't agree with something. And I'm just curious about that.
I don't know for any facts because I don't believe that that is collected data, but I'm sure that there are family conversations and differences of opinion. What's good about this is that it is something that has to happen in a planful way. It's not something you can just do quickly. And so there is time, and especially in the hospice setting, there's time to reconcile those differences. And I have seen situations where patients have gone through with this and they've had family members who were just angry and wouldn't be there. But it ends up, it's always the individual's choice in the end. And they are capable of making that decision. So with them being empowered, hospice people will do everything they can to help the family come to some agreement, but they don't always.
Kathy Gaylord, I see your hand is up. Go ahead.
Yes, I'm wondering if a person who is terminally ill needs to be a resident of the state that allows this, or could a person choose to go to a different state?
That's a really timely question because every state that has the legislation requires state residency, and here's why. As a physician, doctors don't want to have to treat patients differently. And in a state like ours, where there's lots of cross-border medical care, doctors are going to have to say, do you live in Iowa or do you live in Minnesota? If you live in Iowa, you can't have this. If you live in Minnesota, you can. The reason that was put into the law is that if somebody from Iowa saw their doctor in Minnesota, got the prescription, and then went back to Iowa, where it's not legal, their families and they could be at legal risk. So for the safety of the patients, they need to be residents of the state. Now you can move to a state, you can move to California and become a resident there. And the residency requirements are simple usually, and they're not, residency requirements vary, but in Oregon, for example, you have to have an address and either an ID or a voter registration card. So you'll just have to have proof that you reside there. So you don't have to. The hard thing though, and I think, what we fail to recognize is that people are dying and they don't want to leave their homes, their families, move to another state, get a whole new healthcare team. So the reality of that is, and you have to have the money to be able to do that. So that is something that is not a very viable or realistic option, but it is possible. I mean, that's what Brittany Menard did. She moved and early in she lived about 9 months after she moved to Oregon, before she ingested the medication. But she had a glioblastoma brain tumor, and her whole family just moved to Oregon. Not a lot of people can do that. And I say it's timely because there's actually a lawsuit right now challenging whether it is constitutional to require a residency requirement. But I think the residency requirement is really about protecting people from implicating themselves in a jurisdiction where it is not legal.
Jane Schreier, did you have a question?
Yes, I did. You talked about the cost of this process. Is there data about the cost, and it sounds also like there are disparities with whites and non, people of BIPOC people. So how does that?
Yeah, by and large, it's used by white people who are more educated. That's kind of the profile. Lesser use by African American, Latino. But if you look at that, mirrors the case that's true for a hospice use in general, and really healthcare. I mean, in every category of disease, people who are either lower income or live in a marginalized community or underserved community they get sick sooner, they die sooner, they suffer more. So it's not particular to this, but it is the same kind of thing where you have to go to 2 different providers, you have to pay for those visits, you have to buy the medication. Are you being involved? Are you involved with a hospice program that will support you in doing this? Some hospices will, others won't. So, there's a lot to be able to maneuver the system and pay for the things you need along the way. And the medication costs, it's a compounded 4-drug formula, and it costs between $500 and $700.
Thank you.
And it's just one pill, isn't it, Rebecca? It's not like a series of.
No, it used to be Seconal, which it used to be 100 pills of Seconal, which you would open up and dump into a thing and add liquid and drink it. Seconal is no longer available in this country. So it's a 4-drug combination powder that is compounded, and then it's mixed with liquid. And there's a process you go through where you go to just liquids, and then you take an anti-vomiting medication. And so there's steps you go through to successfully ingest this so that it works. You don't want people to drink it and stop, because then they'll fall asleep, So there's certain, there's a drug regimen kind of that's set out that people go through.
But they'll do it, they take it all at once, don't they? Or do they, like, you take something, you don't wait a few minutes to take something else? Or
you take an antiemetic, which prevents vomiting, an hour before, and then you take the medication and blend it and take it, drink it down within a minute, and that's it. And people fall asleep usually within 10 minutes or so.
are these drugs used in other places and for other purposes? I mean, well, the anti-vomiting drug obviously is used for something else, but
Yeah, it's a combination of Valium, morphine, a medication to slow your heart. Amitriptyline is added sometimes. So that, these are common drugs that are used for other purposes, but they're compounded in ratios and at high dose levels that, have this desired effect.
And I see on our chat, Janet Siegler asked a question about the cost, and you did talk about the cost of the medication. Then people would also be paying on their own for their visits to the doctor. Is that correct?
That's right. Some insurance companies do cover this, especially in Oregon, California. Kaiser Private Insurance covers it. And in Oregon, their Medicaid, state portion of Medicaid covers it for people of low income. But no Medicare coverage, no VA, no public employees, nothing that is a federal government or the federal government portion of Medicaid.
Barb, you got a question? Get to unmute.
Unmute.
I'm not sure it's even an appropriate question, but do you remember how in capital punishment they had to stop because they couldn't get the drug to kill people? Why don't they use this medical cocktail?
I have no idea.
Yeah.
Any other questions for Rebecca?
So I'm sure Shannon can share with you the updates as we go, but at some point, the Minneapolis League will be submitting a resolution for concurrence. And I encourage you all, if you support this, if you think your league would like to concur, you can officially concur, or you can just know, if you want to send your delegates to vote for this. If you need to talk amongst yourselves to make a decision about what you want to do, I encourage you to do that, because we expect it'll be up for discussion in April.
Rebecca, how would our league officially concur? Would it be before council or?
Well, the way our league did it was, we had the materials sent out to everybody, and then we kind of did a ballot, and people either voted at their unit meeting or they voted online. And then we just tabulated them, said vote by this date, and we had a majority. In fact, I think we got about 35% participation, but 90% support. So it was clear that our question was, do we concur with the Utah position that I had on the slide? And, you know, our vote was yes. So we were officially concurring, or you might want to say we support concurrence. That would be another way to do it. Do we support concurrence with the Utah position for the whatever? So, you know, I'm not sure there's one right way to do it.
Mhm. Okay, thank you. All right, Barb, go ahead.
Thinking about this next April when it comes up for a discussion again, I wonder if there's any intentional outreach to some of these leagues that voted against it before. We wanted, and Shannon made the invitation possible to have you begin our education, but is there anything that can be done to offer this kind of education to these other leagues up in the more rural areas?
Well, our committee has been working on that. We've reached out. I think we have about 8 presentations in the next month. So they've not been as many rural, but I know we're going to Winona, no, not Winona, Wilmer, St. Cloud, Duluth, Rochester. There are a few leagues that we've reached out to, but nobody knew anybody there and they haven't responded. We'd still like to get to Bloomington. We have reached out to some of the northern leagues. So, I mean, I absolutely, we want to do that. And our committee has been working on that. So if you know anybody in an outstate league that you think you'd be willing to reach out and invite, that's what we just need to do. And we've been going to the, I went to the presidents, all the league presidents get together in a meeting. I spoke there to all the league presidents. And then I was also at a meeting where all of the league program planning people were. So, you know, we've done, and we've sent out emails to the president. So we've kind of been doing as much as we can. And we'll need to get a 60% vote to pass this. So.
Are you recruiting anyone to speak at council in favor of the motion, or have you not gotten that far yet?
We haven't gotten that far, but we will definitely want people to do that. We don't even know who the delegates are yet. We don't even know how many delegates we get yet. So that's kind of a bit of a ways off. But yeah, if you decide to support this and you have delegates coming, yeah, we'd love to have a delegate speak in favor.
Okay, great, good to know. All right, any other questions for Rebecca? I'm going to turn it over to one of our local league people. Oh, hi, Kathy. Go ahead, Kathy Gaylord. You have to unmute yourself.
Sorry, I was just thinking about getting the word out and that it's a state by state issue. What about state media or media within the state? Do you ever see a way that could be useful or no?
Funny you should ask. We're always trying to get, and the thing that is the best education tool are individual people's stories. And I don't know if you've all looked at the January issue of the Minnesota Women's Press, but one of our strong advocates, a young woman, she's 25 and she's dying with rhabdomyosarcoma. And she talks in that piece very, I'll see if I can put it in the chat, but she speaks about why she wants this option. So we've had people profiled in the Pioneer Press, in the Min Post. We've been in a lot of different things, but you've missed them all. So it's hard to saturate, and there's so many competing issues, but it's really the personal stories and talking about those in your local media and, with your family and friends and neighbors. That's how we need to spread the word. It very much like what happened with the marriage equality effort. It really was a lot of people talking about it, grassroots, person to person, and making these, and not being polarizing, but being humanizing in it. And that's what we're really trying to do. So I welcome any opportunity to get things out in the media. I just know it's a challenge, and it can be hit or miss. Let me find that article and put it in the chat.
I remember I listened to Minnesota Public Radio, and there's a a series that's kind of in an intermittent series, but the morning host, Kathy Werzer, is interviewing a gentleman with ALS. And it's kind of like his journey towards death. And it's really interesting that, you know, that because we don't like to talk about death, you know, it's one of these things, just like, don't talk about it. But, you know, this is done in a very thoughtful way. And it just, you know, it's a nice conversation because it's just this one man's experience. And I think that's, like you're saying, it's a story, it's somebody's personal story, and it really is very powerful. So that could be very good. Okay. All right, I think we're going to move over to a couple of announcements. I want to thank Rebecca again for coming tonight and giving us the wisdom of her experience and knowledge, and it's really given me things to think about, and you know, it kind of challenges me to question my beliefs. So this has been very helpful. Thank you, Rebecca.
Thanks.
Yeah.
Thank you.
I wanted to move over and let one of our action co-chairs talk a little bit about some things coming up that people can participate in if they so desire. Lori Hunt, she is our action co-chair. And so Lori, go ahead and let us know what you've got going on.
Okay, thanks. I just wanted to tell people to be on the lookout for 2 emails coming your way in the next 24 hours from your action co-chairs that will be coming via Dick Ottman. There are 2 opportunities available to you. One is to be part of a statewide group of volunteers acting as the League of Women Voter Minnesota's Lobby Corps and Observer Corps. And that has a new format this year and should be very easy for people to join in, and the email will tell you how to find out more information and how to sign up for an orientation. You're encouraged, if you have any interest, to sign up for the orientation, and then you can make your decision after that. So it's not a commitment if you just sign up for the orientation and find out. The other one is an email which will ask for volunteers to do interviews of our current legislators. And so we'll tell you who those are. And we have all sorts of information about how to set those up, what the questions are, what to do with the information. So it should not be too daunting. And if you want to work with a partner to do one of those, that would be fine too. So please open both emails and read them. And I hope that you will decide to participate one way or the other. Thanks.
Thank you, Lori. Okay, and was there could be somebody saying something about January Jumpstart? I'm not sure if that was part of the plan or not, but we've got some programs coming up through the League of Women Voters Minnesota that you can participate in, and I think it's going to be the 26th. Anyway, you can go to the website LWVMN.org and find out more about the January Jumpstart programs that they have going on. I also wanted to remind you all that our presentation next month is going to be about looking at the statewide update study of the firearms position that we have. And so that's going to be, there are going to be 2 meetings, one during the day and then one in the evening. And they're both going to be on Zoom, which is kind of a change. I think one of them was originally going to be in person, but because of the COVID spike in cases, we've decided to move to both meetings to being Zoom meetings. There's one on a Wednesday, the February 9th at 12:30, and the other one is Thursday, February 10th at 7 p.m. And so check your email for the Verifax, and you'll see more information about that, or you can go to our website and see it on the calendar there. So I think with all that, that might be all we have tonight. Does anybody have any parting words? Okay. Well, thank you again, Rebecca. This has been a great information, and we really appreciate you coming out.
Thanks for having me. I really appreciate your taking the time to learn more about this topic.
Yes, and we're going to have that information again on our website, so go there and take a look, or you'll get it in your email too. So Great. Thanks everybody for coming out tonight and we'll see you soon. Be safe.